To undergo a major operation during the Renaissance was to face a waking nightmare. With no anesthesia, patients were physically locked down to endure the saw and the blade while completely conscious. At the time, anatomical education was curiously detached from the physical body. An educated physician would read aloud from ancient, unquestioned texts, while an assistant or tradesman hacked away at a cadaver, ignoring the actual flesh if it contradicted the book. The path out of that dark age began with individuals mapping what was actually there. Leonardo da Vinci conducted extensive, often secret, human dissections, sketching detailed layouts of the organs resting beneath the skin. But the real breakthrough occurred with Andreas Vesalius and his 1543 publication, De Humani Corporis Fabrica. Vesalius bypassed the ancient texts to personally dissect human cadavers, documenting the harsh reality of flayed musculature and skeletal systems. This shift toward direct observation established a new baseline for the profession. For a surgeon to be effective, their first requirement was no longer a library of ancient books, but an accurate mental map of the human corpse. This new observational power was immediately tested on the changing battlefield. As swords and arrows gave way to guns and artillery, surgeons faced devastating, unfamiliar tissue damage. Believing these new gunshot wounds were poisoned, the standard medical response was to pour boiling oil directly into the open flesh to destroy the toxins. The treatment often caused tremendous additional damage. During a siege in 1536, a surgeon named Ambrose Paré ran out of oil. He improvised a gentle mixture of egg yolk, rose oil, and turpentine. The soldiers he treated with this salve experienced less swelling and agony, leading Paré to abandon the traditional use of boiling oil. Paré carried this empirical approach to amputations. Instead of burning severed blood vessels with hot irons, he developed a method of looping a thick thread, a ligature, around the artery and tying it off mechanically. The surgeon moved from destroying tissue indiscriminately toward precise anatomical hemostasis. By securing individual vessels, they gained a deliberate control over the patient's blood flow. True control required understanding the invisible mechanics of the body. In 1628, William Harvey mapped the continuous circulation of blood, providing a rational foundation for managing arterial bleeding and shock. As knowledge of the body expanded, so did the specialized tools designed to manipulate it. The Chamberlain family developed obstetrical forceps to provide mechanical leverage during dangerous deliveries, guarding it as a secret. They banished assistants and blindfolded mothers so no one could see these heavy, curved steel blades or the locked joints of the instrument at work. Later, in 1718, French surgeon Jean-Louis Petit introduced a major advance in limb surgery, an effective surgical tourniquet. It featured a central brass screw attached to a woven strap, designed to manage the massive blood loss of thigh amputations. By turning the threads of that simple screw, the operator could artificially compress the major arteries. This paused the ticking clock of fatal hemorrhage while the surgeon worked. With physiological maps and targeted mechanical clamps, the profession was learning to treat the human body as a complex system that could be halted, adjusted, and repaired. Yet for all these mechanical advancements, the patient on the table was still wide awake. To minimize the extreme physiological stress of surgery, a surgeon's only mercy was blinding speed. This environment created a new breed of high-volume procedural specialists. Operators like Frère Jacques traveled Europe, removing bladder stones in massive numbers, once completing 38 consecutive lithotomies in Paris with 0 reported deaths. Others pushed into strictly forbidden anatomical territory. In 1736, Claudius Amiand successfully breached the highly dangerous infection-prone abdominal cavity to perform an early appendectomy. And when William Cheselden removed a bladder stone, the sharp steel flashed through the operation in approximately 45 seconds, pulling the patient back from the brink of agony as quickly as physically possible. These high-speed feats demonstrated that velocity was a liability without a near-perfect mental map of the anatomy. Precision became the primary filter for surgical success. By the late Enlightenment, this accumulation of knowledge reached an industrial scale. The Hunter brothers amassed roughly 65,000 embryological, pathological, and anatomical specimens to study disease in living tissue. Surgery had shed its history as a despised manual trade. The individuals wielding these organized tools were now respected members of an elite scientific profession. They possessed an accurate map of human flesh, engineered specific probes and hooks to control hemorrhage, and mastered the operative speed required to keep patients alive. But despite centuries of intellectual conquest and mechanical refinement, the enlightened surgeon remained halted just outside the threshold of the modern operating room. While controlling the bleeding and mapping the nerves, the dual threats of conscious pain and microscopic infection remained entirely undefeated, waiting silently by the table.